frequently asked questions on managing the violent patient. What are the conditions predisposing patients to aggression? Current psychosis, especially with paranoid delusions and hallucinations. Mania, for example in bipolar disorders. Central nervous system infections. Delirium resulting from sepsis, metabolic causes, for example hyperglycemia, and organ failures. Drug overdose. Substance intoxication, especially stimulants, alcohol. Substance withdrawal. Brain trauma. Borderline, antisocial, paranoid personality disorders. What are the warning signs of aggression? Loud talking. Profane, intimidating or overly sexual language. Demanding unnecessary care. Accusing clinicians of conspiring against the patient. Throwing or punching inanimate objects. Agitated behavior, for example, rapid pacing, darting eye movements, invading personal space, clenched or gripping hands, clenched jaw. Inability to comply with directions and/or reasonable limit setting. What are the strategies to approach a potentially violent patient? Approach the patient slowly from the front or side rather than from behind so as not to startle them. Maintain a safe distance to provide safe personal boundary as well as safety from assault, at least 1 arm's length away. Mirror the patient's body language, sit with seated patients, stand with standing patients and walking alongside pacing patients. Not in front because you cannot watch what the patient might do, and not behind because the patient becomes suspicious and paranoid of you. Introduce yourself as a doctor and remind the patient of your benign intentions, especially to those with inattention. What are the environmental considerations? Some environmental considerations to deal with a potentially aggressive patient, or family member, are as follows. Remove the person from an overstimulating environment. This includes removing potentially disturbing individuals, other patients, staff or family. Conduct the interview and assessment with the patient in a calm environment. The room should be large as opposed to claustrophobic. The room should enable the doctor and patient to maintain a safe distances. The doctor should be seated between the patient and the door. A clear escape path is possible. Such an arrangement also enables the patient to have a clear view of who is coming in or out, and this provides a sense of security to him, her. The furnishings in the room should be robust and not usable as projectile or sharp objects. While privacy should be considered, help should be readily available when needed. Planning people on standby and ready to intervene when alerted with a coded signal may be required. What are the ways to de-escalate the situation of anger? Adopt a more empathic approach. Acknowledging the patient's hurt is often a good starting point. It is therefore useful to hear out their grievances without trying to correct their perceptions. Being genuinely interested in helping the patient solve his or her predicament can stop the anger and aggression at their tracks, because these states are often predicated on the expectation that you will struggle with them. It may even be possible to convey that you will work with them to find a solution, though it may not be the one they had in mind. This may then shift the patient away from aggression and towards a negotiation for a win-win outcome. What to do when anger has evolved into rage? When anger has evolved into rage, the situation is close to being out of control. The patient just needs any slight reason to lash out. Saying to the patient that he would rather that things not get worse and that he can choose to have things under control may reinstate his sense of control. By empathizing the patient's difficulty with control, we can then suggest if they would like treatment to calm down. Even among disturbed patients, a sense of personal control may also be established by choosing between oral or injection medication. What to do if things get out of hand? When this happens, finding any reason to have a pause, changing of physical environment or a change of the healthcare worker. Let me speak with my supervisor. Recognizing imminent danger is crucial. The doctor should not hesitate to recognize that negotiation has failed and to call for help, and indeed run away from danger. This is particularly important when the doctor is alone or is doing a home consultation, where there is little control of the environment and reinforcements are unlikely to respond in time. In other care settings, the security staff and police may be mobilized. An assemblage of staff may also signal to the patient to instinctively back down. It is always desirable for the patient to have a chance of quietening down under observation. Engagement can be re-attempted when the emotionality has subsided. But in a patient who is likely to harm others or themselves, safe and rapid restraint should be considered. Physical restraint should be attempted only when necessary and by trained personnel. The lone doctor in the community may therefore choose to wait for reinforcement by police and ambulance care staff. What is the acute pharmacological management of the violent patient? In terms of acute pharmacological management of the violent patient, the possible agents may include the following: haloperidol injection, haloperidol oral solution, tablets, lorazepam injection, lorazepam tablets, olanzapine tablets, risperidone tablets, liquid.
Audio Jungle. Audio Jungle.